Welcome to another episode, another podcast, Interpreting for Healthcare, Ensuring Language Access for All, from the Standards and Training Committee at NCIHC, the National Council for Interpreting in Healthcare. We are really pleased to have a very special edition today with several guests who are on the front lines at the very beginning of the creation of the National Council and the push from within by providers actively calling for participation of trained healthcare interpreters in the provision of care to those patients and families that were limited in their English proficiency. I am so thrilled that we have several of the stars of the early days and recent retirees who have time to participate in our podcast. First of all, co-hosting today with me is Yulia Sparov, English Russian Core CHI, Washington DSHS Certified Medical and Social Services Interpreter, who is the current supervisor of interpreter services at Harborview Medical Center in Seattle, Washington, a role that we share in common, which is why this gathering is so sweet for me personally. Yulia is certified as both an English and Russian language instructor with more than 10 years of teaching experience, which makes her such a good trainer for both in-house and through the conferences and other online opportunities that are available to all of us who, as working interpreters, are looking for those continuing education opportunities. I also happen to know, as Yulia herself was too modest to mention, that she was named and honored as Interpreter of the Year by CHIA, the California Healthcare Interpreters Association. Just, was it last year, 2021? I'm getting old, it's all starting to meld together. Congratulations, Yulia. Now, among our guests, the recently retired Carrie Jackson. Until this year, until just past July, right, Carrie? You served as Medical Director of the International Medicine Clinic, Refugee and Immigrant Health Promotion Program, the Northwest Health and Human Rights Coalition, and an Interpreter Services Department at Harborview. You're a general internist with graduate training in anthropology and public health, with extensive experience in the practice of cross-cultural medicine, community health promotion, and health services research among diverse immigrant patient populations in Seattle. Your professional interests include refugee and immigrant health care, health services delivery to non-English speaking poor, medical anthropology, health disparities, and disease prevention. Now, two things that I noticed when I was supervisor of interpreter services at Harborview was the website Ethnomed, which is really unique in that it is meant for providers who are interested in their limited English patients and their families, and getting to get a little bit more of a handle on where they're coming from and what their expectations are and how they could differ from the typical English speaking patient. And also the fact that you brought interpreters in to train residents in practicum scenarios that were built around typical situations, and that intern or resident would have to practice doing their workup and communicating with the patient through the assistance of an interpreter, something I had always wished for and never seen. Our other very special guest is Dr. Eric Hardt. He's from the opposite coast, the East Coast, a former associate professor of medicine at BUSM. His training included a BA in Psych from Yale in 1970, an MD from Tufts in 1974, and then 10 years at Harlem Hospital and Jacobi Hospital in the Bronx, New York, training and working as an internist, geriatrician, and oncologist. He then came to Boston City Hospital, where he worked for 34 years until his retirement. He's been board certified in internal medicine, medical oncology, geriatrics, and palliative care medicine. Dr. Hardt's activities in the area of non-English speaking patients and medical interpretation are well known around the country. He's produced educational materials for medical interpreters and for healthcare workers working across language differences. He's authored and co-authored book chapters and articles on medical interpretation and related areas. He's regularly spoken on these issues at conferences, grand rounds, and other venues, and in a few other countries. Dr. Hardt was a founding member of the International Medical Interpreters Association, originally the MMIA, the Massachusetts Medical Interpreter Association, which then morphed into the IMIA, the International Medical Interpreters Association. In 2011, he received the IMIA Inaugural Provider of the Year Award. He was a founding member of the National Council on Interpreting in Healthcare and served on its executive board, co-chaired its policy and research committee in the past. He's worked with Massachusetts Office for Refugee and Immigrants and with the ABA's health law section about related legal issues. More recently, he served as founding board director for the National Board of Certification for Medical Interpreters, which began national certification in 2010. And for 34 years, he served as a medical consultant to interpreter services at BCH and BMC. He remains a member of IMIA and NCIHC. And most recently, like our very first podcast guest, Vanessa Costa, he received the UMass Medical School Tony Windsor Award. So an illustrious group here today, people that have lived and studied and worked and learned from the limited English proficient community and have so much to share with us about the challenges facing language access in healthcare today, what we need to do to improve the delivery of those services. And part one, how did we get this all started? So Yulia, I hand hosting responsibilities off to you. You can ask the first question, and be careful when you start with Dr. Eric Hardt, because we want to save some time for Carrie.
Thank you. Thank you, Liana, for starting us off. I would like to address my question to both of you, but I'd like Carrie to start with you. So I've known you professionally as my boss's boss, as our medical director, and as a outstanding provider. I even interpreted for you. But at your retirement party, one of the guests, Cindy Rowe, talked about how you were at the very foundation of the NCIHC and talked about you being a language access champion. And as we were planning this episode, Dr. Hardt also talked about working with you at the very first NCIHC meetings. And I'm very new to NCIHC Standards and Training Committee. And to be honest, I do not know much about that history. So I'm very much curious to learn how and why did you get started with NCIHC? Because from what I understand back then, this wasn't a national council on interpreting in healthcare. It was a group of language access champions in Seattle who started talking and thinking about it and brought the organization eventually to what it is today. Carrie, could you tell us a little about those early days?
Yeah, I'll be brief because I was late to the party, and I'll just kind of give you a little of my timing and defer then to Eric to sort of talk about the early days. When I came to Seattle, it was 1990. So this started much earlier than that. And when I came to Seattle, we had a lot of local activity, a woman named Sherry Riddick and others who were working, and we had a consortium of interpreters that worked between the health department, PacMed Medical Center, and various clinics, some of the community clinics, and Harborview. And so it was organized out of the health department, and it was a shared service. As the 90s went on, then people became siloed. PacMed had their interpreters, Harborview had its interpreters, and things became fragmented in a funny way that have now been reversed by telephonic interpreting. But in those days when I first arrived, Bob Putch was already here and based at Pac Medical Center. And as Eric will tell you later, Putch was a huge force in the early organizing of interpreters and the utility of interpreters in medicine here in Seattle and then nationally. And I think that it'd be lovely if he were on this call because he could talk with Eric more about those early days. I think that my role in interpreters came later when I began to quote speciate them into navigators and block interpreters and begin to take interpretation in different directions. But the early days, I think I'm going to defer to somebody who was actually there. I played a role, I think, just in supporting that organizing activity, nationally turning up to meetings and that sort of thing, but not as instrumental as Eric and Bob in those early meetings.
Right. Thank you, Carrie. All right, Eric, same question for you. How and why did you get involved with NCIHC?
Well, I'll try not to be too long, but I'll start when I was age 7. At Nana's house, my grandma, whom I loved dearly, was an immigrant, illiterate, from Calabria, Italian speaking, and she was a bad diabetic. And when her doctor, Dr. Hardt, my father actually, a general practitioner, made home visits to visit her, my cousin would come down from upstairs and quote interpret for him. And I had learned enough Italian to realize that my cousin was not telling her doctor what Nana was trying to say. Her needle was damn dull, excuse me. Her needle was, she needed a new needle, but Jerry would say everything was okay. I was very angry, tried to interrupt with my own little Italian. I was told to be quiet and go to my room. I forgot about that until the 1970s. I graduated med school in 74, spent 10 years in New York City, Harlem Hospital in Jacoby in the Bronx. And in those days, if we did not speak a patient's language, they were treated as though they were not real patients. It was almost a veterinary approach. Sometimes they would come from a note from a relative and we would just do an exam and then write down our orders for tests and treatment. The charts would usually have the phrase history unobtainable secondary to language barrier, meaning I'm doing my job, I love my patients, but this time I can't do my best work. It's not my fault. When I went to Jacoby in the Bronx for 5 years, an elderly retiree pediatrician, wonderful man, had generated a list of employees who spoke another language. These were virtually all immigrant women with full-time jobs in the kitchen, cleaning ladies, etc., etc. And they got paged overhead. Can the Polish interpreter come to the primary care clinic? And they had to stop what they were doing and come and help us with the patient. If they were not available, we'd go into the waiting room and say something like, is there anybody here who speaks Polish? These were considered normal. After a 10-year sentence in New York City, I came to Boston in '84 and very quickly in 1985 met Raquel Cashman, the country's first and very well-known full-time director of interpreter services at Boston City Hospital. And we realized we had some interests in common, although we were very different. She had been a nurse and had come from South America. I was a white boy from Connecticut who only spoke English. And as she started to develop her Department of Interpreter Services, she was basically treated as though she was a sweet woman who loved the immigrant community. Okay, next case. And I told her to appoint me as capital letters medical consultant to Interpreter Services and to bring me to every high-level meeting with physicians and other high-level administrators. And I would basically use my leverage point as an entitled physician, English speaking, who demanded every tool I wanted and needed to do my best possible job to avoid mistakes, unhappiness, lawsuits, and whatnot. And it was not because I loved the community. I never mentioned Nana in those meetings, but they would kind of think of me as having a good point. Gee, maybe, and it was sort of like demanding that we needed a CAT scanner, even though they were very expensive in those days. So the issues came up of what would it cost to have real interpreters, who would pay for it, etc. So basically for 35 years, I followed Raquel Cashman as she co-started the MMIA. I was there for all the meetings and always basically listening and learning about cultural and language differences. And then when I had time to speak like I do now, talking about the physician's point of view and how we could convince physicians that they needed real trained medical interpreters, not just ad hoc family members or the cleaning lady. And from time to time, when we needed to, I wasn't a full-time. I was a full-time clinical doctor. That's what I love to do. But if I needed to do a little research to show that using an interpreter saved money, we would do the research, go to Capitol Hill in Boston, and get them to pass Tony Windsor's first state law requiring medical interpreters in the state of Massachusetts. But I'll go on pause with this. When I was reading JAMA, the Journal of the American Medical Association, the most widely published medical journal in America, then and now, I opened it up and the lead article was by Robert Putsch. It was about communication in healthcare with a subtitle, "The Special Case of Interpreters in Healthcare." That was the first time I saw the word interpreter used in any medical publication. And I basically hurrahed that there was another doctor in America who seemed to care about this and maybe even knew more about it than me. So we started trips back and forth between Seattle and Boston and other parts of the country as organizations for medical interpreters were developed. I spent most of my time learning from those organizations, spitting out the doctor's point of view, and then going back to my job of training medical students, residents, and sometimes nursing students, social work students, physical therapists, etc., about how to work with medical interpreters, which I had learned from all of those organizations. I sort of realized that I had a great leverage point in the Society of General Internal Medicine, the American Geriatric Society, American Public Health, et cetera, where I could raise issues of language differences and tell everybody to avoid that phrase, language barriers. Barriers means that implies this is an excuse. It was a wall I couldn't climb up. It wasn't my fault I did a lousy job. No, if we said that there were gender differences or religious differences or class differences, barriers, if we call them barriers, people would open their eyes. But for the immigrant population that now, in particular, not everybody in America was welcoming, it was treated as though it was a barrier that could not easily be climbed up and down the other side. And finally, I'll say, when I started seeing the name Carrie Jackson at Harbor View, I thought that this young fella, he was recently finished his training and I was already in my early 40s. And I thought, wow, here's another doc who might even last longer than Putsch and I and become a real advocate. And our paths crossed back and forth as the national profession emerged, evolved, and whatnot. And now that we're both retired, I spend most of my time working in areas of advocacy and education for the evolving profession of medical interpreters. And I have some very specific ideas about how that profession will evolve in the same way that the medical profession evolved from the 19th century. And I'll give up the podium somewhat reluctantly now, unless there are any other questions.
All right. Well, thank you so much, both of you, for answering my question. And I would now like to look at it a little bit wider. And Dr. Hardt, you touched upon it somewhat. So both of you are medical providers, retired medical providers. This is your first job, primary job, but you're both very interested in championing language access. So can you talk about why and how can medical providers get involved with language access? We'll start with you, Carrie, please.
I hate to change the focus, but I was not all that interested in language access. I was much more interested in culture and power. That's why I trained in anthropology. And I wasn't that interested in medicine. I was interested in anthropology, and I thought within American culture, there are two sources of power: business and medicine, business and technology. And so if you want to nest yourself someplace and study power, that's a great place to do it. And so everything I've done was much more interested in sort of cultural difference, but language comes along with it, obviously, right? And we can talk about how that works. And so that's why I trained that way. I think that probably came from, I'm from like 3-4 generations of missionaries. My mother was raised in Central America, and my father wrote in for his graduate work, a dictionary. It was his thesis, was a dictionary of tracking the uses of words throughout the various zones of Latin America, so that a word that was used one way in the Platte River zone was used differently in Central America, used differently, and how those, and he had a whole dictionary of those things. So that was happening when I was in probably middle school. And so my family's sensitivity to just changes in Spanish language, which is a Romance language, which is European based. And so the analogs there were even some of the sort of phraseology, accents, and word usage made it clear that language not only varied widely, but represented power, right? And I don't want to delve into that too much, but anyhow, so that was kind of the lens at which I went to language access, to touch on your focus here, was from that perspective of mediating power with people that have been colonized and that are now seeking help by people that colonize them, and how that gets worked out in settings like hospitals and clinics. And that explains, I think, a lot of the research that I did through the years and the services that we delivered. I don't know if it's helpful, but that's what brought me to it.
No, it is so fascinating. And it's interesting. I'm seeing the themes of kind of family influence and, picking up potentially interests that were instilled in us by our families. That's amazing.
We need to discover the formula so that we can create more physician language champions or power differential acknowledgers, or
I gotta say, this generation gets it. When I was coming into medicine in the 90s, I can tell you, I interviewed for the Robert Wood Johnson program, and the people that were interviewing me didn't have a clue. I mean, their eyes glazed over. It was all about outcomes and evidence and very narrow algorithms. And so they didn't see where I fit. And so there was very little interest. But this generation understands, I think, equity, diversity, and inclusion in a way that previous generations didn't. They just get it. And that's, I think, largely because of LGBTQT issues, as well as other issues that bring the idea of diversity and power and privilege, et cetera, right to the fore. And the medical students and the residents don't bat an eye, whereas before they used to really struggle with it. They thought of it was really relevant to psychiatry because of Kleinman, I think, and Byron Good. And then they sort of reluctantly began to realize, oh, there are structures of power. There are structures of inequity, And this is, I think, Paul Farmer sort of championed a lot of that stuff as well. And it didn't focus on language, right? It focused much more on culture and structures of power, which is what our generation of people in anthropology were interested in. And so language becomes a part of it.
I thank you for that. And I agree with you. Whenever I talk to incoming interns or residents about working with interpreters, and whenever I ask a question, have you ever worked with an interpreter? Have you ever been in a situation where you acted as an interpreter? Inevitably, I hear stories of having to interpret for, parents and grandparents. And so this lived experience, I feel, really informs doctors about future doctors and training doctors about what should and shouldn't happen during patients' communication with their providers.
Right.
Thank you for that. All right, Eric, same question.
Quick comment about the old days in New York City. We had at Harlem Hospital in Bronx, we had a somewhat diverse, for those days, staff of physicians. It included women, which, in 1847, the AMA excluded them from the profession, as they did Black people. But there was a tendency, if a patient spoke Spanish, some of us, and not necessarily me, would say, oh, wait a minute, Jorge, he's from the Dominican. Let's send all the Spanish-speaking patients to him. To which I felt like saying, gee, I would love to have more Italian-speaking patients, but I want to be able to send my patient to the head of cardiology who only speaks English. So, we need and have an increasingly diverse and inclusive healthcare team. But that does not, medical interpretation should not substitute for that. And we should not segregate by language the patients that we're taking care of. Yes, a young doctor with a third generation from another country and language and religion and whatnot might be thrilled to have an increased number of patients like that, but it should not be a segregation solution to that job. And looking ahead, I would say we need to train not only physicians, and the focus has always been on this, but we need nurses, physical therapists, dietitians, social workers, you name it, chiropractors, acupuncturists, who get the training that us MDs get about how to, quote, work with interpreters. And interpreters need training about what a physical therapist is trying to do, what a psychiatrist is trying to do. And my prediction is that we will have subspecialized medical interpreters who are particularly equipped to deal with OBGYN stuff, pediatric stuff, geriatric, psychiatric, and whatnot. And then until I get asked to shorten my speech, I will say one thing that bothers me is when the first interpreters started working in Boston City, they would come into the room and the young docs would stop what they're doing and say, "Excuse me, who are you? Oh, what, like, do you speak this, whatnot?" Because there was no name tag with initials after it. If a nurse came in that said RN, it would be, "Okay, can you help me with this? You want to do that?" So SW, PT, OT, all the same. So my feeling is that because this profession mostly started with immigrant women, they have always been treated as though they were not full professional members of our team. And I asked the question, if I'm talking to an old man about erectile dysfunction, or a woman about how she got the black eye in her home, or a teenager about how much alcohol he's drinking, the only people who are ethically allowed to be in that room are people who are trained, certified, and even licensed by state. If the housekeeper or secretary or security guard knocks on the door and comes in, we immediately stop what we're doing because they're not totally authorized, certified, and trained members of our professional team. So I'm hoping that before I die, every interpreter that comes into that room will have the same kind of credentials. There won't be the same criteria for getting a license, for taking certification tests and recertification and whatnot, but they should have those initials after their name so they're treated respectfully, and everybody that works with them should be trained about how to work and not treated as though it's just a trivial incidental situation. So that's my thought looking forward. And for us docs, and hopefully every other medical professional leadership should be advocating for medical interpreters to join our professional team, do the work that we love to do, and do it without mistakes, without wasting money, without making people, providers and patients, unhappy with outcomes.
Thank you. Thank you for that. Another question I'm really curious about is, so it sounds like both of you were kind of talking about, when advocating for language access or power differentials, you talked about using the language that the other parties would understand and would care about. And so it might, when Eric, you were talking about
Raquel Cashman. Oh, I will never forget that woman. She is responsible for how much I enjoyed my career.
So, Dr. Hardt, when you were talking about Raquel Cashman, you mentioned how she wasn't necessarily taken seriously because she wasn't, the things she was saying weren't resonating with the execs or with the doctors. And so my question to both of you, as providers talk about language access or talk about breaking down cultural barriers or cultural differences, what are some things that they could potentially focus on to be heard and to make other people care about it? Carrie?
I think that, sort of knowing how hospitals work, their risk is one thing that figures highly with hospitals. And I think Eric alluded to that when he was talking about pointing out that docs need or pharmacists need interpretation to be accurate, minimize risk. And I think that cost is the other huge thing that administrations listen to. So, you know, you don't always sort of make your point for the right reason. Sometimes you make it for the wrong reason, but it's how you get heard. And this goes back to power, right? So that the issue there has to do with cost containment. And I think that you know, so wound care, post-surgical, you think about some of the work we do around surgical work with John, you know, with JT, you know, in terms of people getting really clear wound care instructions so that they don't have to come back for revisions or for infections. And then discharge instructions, et cetera, that are very clearly given. So those are cost containment kinds of arguments that you make to the administration to pay for this stuff. I think there are other, we can sort of talk about innovations that come with time, but I think there are different ways of looking at cost containment, and some of it has to do with sort of routinized practices, right? Routinized things that how to do a UA, how to do a clean catch, how to do a COVID swab, how to do these things that get done repeatedly in a language that take an interpreter offline in a sense to do something very routine, because we have limited interpreters, right? Let's say you have at any given time at Harborview 50 Somali appointments and you got 6 Somali speakers, you know, so there's 44 people not getting an interpreter. Where are they getting those interpreters and who's doing that work, right? Because the others are deployed. And so what other resources are available to go to do that work? And I think when you start getting into the weeds like that with administration, then they start to care about it, and interpreter, and then the providers and the pharmacists. But I think to Eric's point, it really is very, sometimes not so much talking to docs get it, and certainly the residents and medical students get it. I think it's really sort of making sure it's clear radiology and it's clear to pharmacy, you know, to PT, et cetera, that they have interpreters to do their jobs. Otherwise they get, they're going to just have a non-adherence because people don't understand what's happening.
Eric, same question.
Well, one thing I would add is I agree totally with Carrie, and but we do need data. And I know that the first piece of research we ever did was in the Boston City Hospital emergency room. That basically showed that people who used ad hoc interpreters were more likely to come back to the emergency room for the same thing, less likely to make their clinic appointment, et cetera, et cetera. This wonderful study at UMass showed that when you didn't use real interpreters, trained interpreters, the length of stay was a day and a half longer for admissions, and readmission rates were higher. And then Raquel Cashman and I, when we went again to Beacon Hill, we took her budget, her total budget, divided by the number of contacts with interpreter services, and we came up with a number. And as an entitled physician who needed all of the available tools, I said to the Ways and Means Committee, show me a doctor who wouldn't order a test or a treatment because it was too expensive, because it cost $17.50. And almost very, very soon after that, the law was passed, although they limited it to emergency rooms and psychiatric facilities. And then the second thing I will say, we were harassing or pestering, I would say, the Joint Commission for Accreditation of Healthcare Organizations, Joint Commission. And basically we told them about why they should have standards for dealing with language access. And they did their own study, and their study showed that even though the number of incidents reported for LEP patients wasn't higher, that the severity of those incidents was much worse, and the cause of those incidents was much more likely to be due to communication failure. So they established standards of care now, which when the Joint Commission comes to your hospital, your clinic, your nursing home, you have to, on paper, say, I agree with your standards and I will hold by them. And if you're a hospital in Boston and you fail to do that, you'll make the headlines in the Boston Globe, and you'll be embarrassed, and everybody will lose trust in your hospital. And then the final thing I'll say, in order for lawsuits require an established standard of care. In order to, a lawsuit requires standard of care, violation of the standard of care, damage to the patient that was caused by that violation. And once the Joint Commission got us to sign in writing, I agree with the things that for language access that you demand in your standards of care, medical malpractice cases, most of which are never publicized, have gone shot up because once the standard of care was established. So again, cost, and legal aspects, particularly malpractice, I found to be two great leverage points that us docs could use and if all we talked about was social justice and our love of America full of immigrants, we might get eyes rolling and not to be taken seriously, even though that's at least partially what we're all about.
I think you've made a wonderful case, and all of us wish we had a Dr. Eric Hardt or a Dr. Gary Jackson in our hospital advocating and being a champion for us. But what I recommend for all of you out there working as staff interpreters or program administrators is find that champion. Just like when we introduce new technology, you want to find that early adapter, that person that likes gadgets and trying new things. If you look, you will find. Carrie, you said the most encouraging thing I think I've heard all year is that the new docs coming in, they get it. So find some of those new docs who are willing to be your mouthpiece in the C-suite so that we can get everybody on board and all of us pointing in the same direction. If you've ever tried to walk 3 or more dogs at the same time, it's really important that we all be facing in the same direction when we take off. So with that, I want to hand over back to Yulia, who will sign us off and get us started for part 2, further in depth with Carrie. But thank you so much for being with us here today.
And someday we'll all get together in person and continue these discussions, debates, and try to remember what things used to be like. Remember, it is as it is in racism. Without looking back and seeing what it used to be like and the pathway we've taken so far, you'd have more difficulty seeing what our pathway forward is. So having a few old guys, not that you're old, Carrie, having a few old guys around who can look back that far as to how horrible it was, to remind you, never go in that pathway again, keep going forward, and we'll be with you. And thanks for letting me participate. Carrie, we'll meet again.